good afternoon or evening, depending where you're joining us from tonight. My name is Melissa Strelinsky. I'm the Vice President and Education Chair for the PASIG, and I am very excited to bring our circus arts experts to you today to share their insights, their backgrounds, how they started treating the population that they now serve. So, um, we are doing our best to address the topics that were submitted ahead of time. If there are other things that come up, you can feel free to put them in the chat and we can address those as we go along. But we're going to cover kind of an introduction to give you everybody's background so you know what kind of setting they're in. Then we'll go through common injuries in the circus arts population, then moving into how to establish a circus arts population or practice focused with those athletes, and then wrap up with kind of clinical pearls and strategies, talking about different return to performance, return to work with the varying loads and requirements that everyone from recreational athletes to professionals need. So on our panel this evening, we have Heather Heineman, Dawn Muci, and Emily Scherb, and I will just kind of guide you through their introduction. So let's start with Heather.
I always have trouble with unmuting. Hi, I'm Heather Heineman. I'm actually a supervisor PT at the Harkness Center for Dance Injuries. Went to Columbia for my DPT, and I've been a physical therapist for about 13 years now. And initially started as a dancer, and right before going into school, started doing more circus type activities and helped inform my education as I moved forward.
Great. Thank you, Heather. Dawn, can you tell us a little bit about yourself?
My name's Dawn. I have been in PT for a much longer time than 13 years. We'll just leave it at that. And I am not a performer. I'm not a circus performer. I got into circus arts when I was working at Walt Disney World in the work comp clinic, and we kept seeing all these gymnasts. There were tumble monkeys, all these crazy acrobats down at Disney, and that's kind of how I got my foot in the door. That's it. Nothing else.
Great. And then Emily.
Hi, I'm Emily. I'm based in Seattle, where I have a small clinic where I actually focus on working with circus artists. I was a professional circus artist in my previous life prior to becoming prior to going to grad school for physical therapy. In fact, prior to going to college for my undergrad. So I was a professional artist first, and then really think that a lot of my ability to watch movement and understand and appreciate movement came from that circus background. I'm sure many of you have a dance background and kind of very similar. Like you learn to watch movement differently and you can take that into everything else you do. So I think one has really informed the other.
Wonderful. And they all forgot to mention that they were featured authors of our Circus Arts ISC. So that's kind of why they were pulled to be our panelists for the discussion on circus arts. So we'll keep moving along. We're going to have our panelists cover the common injuries seen in circus artists. So Emily, we'll come back to you, and Emily will start with the upper.
Already knowing Dawn and getting to know Heather doing that, and it's been really fun to continue to collaborate with both of them kind of moving forward too. So it was a great project. So upper extremity or upper quarter injuries in circus, probably the most prevalent is going to be the shoulder. It is by far an area that is used very, very differently in the circus arts compared to other sports and other activities. If we think of overhead athletes, we're really talking about, we often are talking about baseball pitchers, and here we're talking about circus artists. They're up here, so they're doing handstands, they're hanging. So we've got the shoulder in extreme end range under a traction or a compression load. And so the shoulder is often that injured area. It can be an acute injury, but more often than not, it's a acute on chronic or a chronic injury, an overload injury, because they may not be prepared for that true end range loading of the shoulder. And that can be a labral tear, that can be rotator cuff impingement, it can be bursitis, it can be all sorts of things. But basically it comes down to not having the strength all the way through their end range of motion. So that's probably one of the most common. If we go back to some of the literature, if you're looking in that kind of pre-professional, professional, community-based population, so not necessarily like our elite folks, but if we're talking about like people in your community that you're likely to see, about 22% to 25% or so of those artists are going to be shoulder, according to the literature. In my clinic, it's like 80%. It's a lot, and part of that is because I see a lot of shoulder as well. The other really common upper extremity injuries or upper quarter injuries, one of them is concussion. For obvious reasons, that's because they knock their head on each other, on the floor, on an apparatus. They can get whiplash from landing in a net or an airbag or that kind of thing. So always remembering that whiplash is also a contributing factor to that concussion. The other big ones are epicondylitis, so elbow, medial, or lateral epicondylitis. And that can be due to a lot of gripping or trying to balance and control. So that can either be our hand balancers, balancing and controlling on their partners, or from gripping with a vertical grip or a horizontal grip. Folks can extend and overgrip that way or be overgripping this way, or just not matching that load to that tendon ability to catch up. And then the last injury I want to touch on is going to be wrist pain. So pain with weight bearing in the wrist is the other really big common one, actually, as pole has gotten more and more common as a sport and a hobby for a lot of our folks. I'm seeing a lot more wrist injuries. That can be a TFCC tear, that can be a scapholunate joint mobility issue, or it can just be, again, also can also have problems with that. And I think there was a question that, Melissa, I don't know if we talked about, even though we just had the conversation about like what makes this population a little bit different. And so like other performing arts populations, the hypermobility rates are a little bit higher as well.
And then if we move to the lower quarter, Dawn, what do we see in the lower quarter in these athletes?
So I also worked at Cirque du Soleil for like 12 and a half years. So that population itself, because they have over 300 shows a year, and depending on if it's tour or resident, they have to do sometimes 8 to 10 shows a week. So lots of chronic overuse in the lower extremity. Even if they're aerial artists that Emily was describing, they still almost always will have a lower extremity load because they'll have to do cues and running on stage and pushing props. Da, da, da. So lots of anterior general knee pain. Ankles obviously are the big one that's going to get injured. And I feel like by the time we got the performers at Cirque, usually their ankles were already kind of gone through the ringer, to say the least. So lots of stability work, lots and lots of managing without tape, without braces. Aesthetically, the performers really can't wear braces oftentimes. If they do, it almost has to be incorporated into the costume, into the outfit. You know, if you're flying through the air and you have this big bulky brace and you're going to land on somebody, it's a danger for the other person. So have to take all that into consideration with this population, that you can't just put a stability brace on somebody's ankle. You can't just put that on their knee. They're going to be jumping on a trampoline and landing on somebody's shoulders. That's a high risk. So I'd also think that because this population tends to do a lot of end range that Emily was discussing, also in the lower extremity, so lots of splits, lots of various poses or images, so lots of FAI stuff, end range, labral tears. Labral tears aren't necessarily bad in this population, I would say. They almost have to have it, so you just have to, again, kind of what Emily was saying, manage that end range and make sure they're stable enough. So lots of end range, lots of chronic overuse, and you're not going to get, at least at the Cirque level, you're not going to get a nice healthy ankle that's never been rolled on. Like, these ankles have been used previously. Let's put it that way.
And then Heather is going to touch on pelvic floor injuries.
Yeah, so actually, Emily Scherb, Brooke Winder, and I recently did a survey study of Circus artists to try to figure out how prevalent pelvic floor dysfunction was. And it turns out, like with a lot of high level athletes, there's a lot of pelvic floor dysfunction. With our research, we could really only focus on females, but we saw 46% of female aerialists had stress urinary incontinence, which makes sense. You know, there's aesthetic concerns about how they look. So there can sometimes be eating disorders, which can be a causative factor for pelvic floor dysfunction. Emily's talked about hypermobility. That can be something contributes to pelvic floor dysfunction. There is lots of power and pulling and pushing, so a lot of intra-abdominal pressure that happens, which can overload and contribute to pelvic floor dysfunction. Most of the factors that we saw in our study, because we can't capture everything in our little research survey, but it was like age over 40, pregnancy, parity, history of falling off a tailbone. Aerial artists never do that, or impact through the pelvis, which again. And then we also, one of the high injury locations in circus artists is the lumbar spine. And a lot of times, if there's hip or pelvic or lumbar injuries, it can also correlate with pelvic floor dysfunction. And then we noticed like 55, I think, pelvic pain too.
And then just continuing on the common injuries, since the three of you are in different practice settings with recreational artists to up to the professional level, can you speak a little bit about what, if there are any trends that you see, say, in the novice performer compared to the professional? Does it mirror what we see in dance and our other, artistic endeavors? We can go same order. Emily.
I'll jump in. It's interesting because I feel like there's different factors here. The most obvious to me is like there's a reverse curve. So true novice beginners don't really get injured yet because it's too new. As they get interested and they start taking multiple classes a week, that tendon load can't keep up with the muscular growth. That's when that epicondylitis is pretty common. Or like we start getting the overload at the shoulder or the hips at the end range. And then there's a drop for a little while as they kind of settle into their bodies. And then those professionals, it starts peaking back up again as they have more demand, as they're doing higher skills with more dynamics, or they get into contracts where they actually can't train as much. So that's one of the problem. I know Emily Powers on this call, so she knows from the New York scene over there that a lot of the performers, like on Broadway, for example, like they are performing so very much that they don't actually have a chance to maintain their own training, and they can get out of those shows and actually be in less good shape than they were to start. So those are all like interesting issues. The other thing that is fascinating that we're seeing is a huge shift of the idea of body care and self-care and utilization of resources. One of the things as folks are coming out of school now, so if they are going to a professional training program, they are expecting to have that level of care and support from their like performance medicine team or an athletic trainer or a PT, and they're asking for more care. And that the companies, I think, are scrambling to keep up with that a bit. So I have heard from a couple different shows that they're like, oh, kind of we used to discourage usage, or like if people used care more often, they weren't necessarily going to be renewed for a contract because they're worried about them breaking down. And now the artists are kind of fighting for, no, I'm doing this to maintain my body versus I'm doing this because I'm constantly injured. So I think we're really kind of in the last 2 years and in the next 5 to 10 years at an interesting point where the artists are taking back a little autonomy. And I think we can learn a little bit from the dance world where folks have been a little bit better about bringing those numbers to show how much we actually can contribute to keeping them up and running.
Great comments. Heather or Dawn, do you have anything else to add? No. Okay. So then moving into a little bit more specifics about how each of you kind of developed or established your circus arts practice and really tailored to treating this population. Let's start with Heather.
So, as I said before, I have a dance background, and I had started doing circus recreationally before I started PT school, and continued through PT school. It's a community. We point that out in the ISC that it becomes very much a community. They're smaller groups. That's not huge studios with 500 million people. So people get to know you in the circus communities. And as I became a PT, people were comfortable coming to see me at the Harkness Center for Dance Injuries. So it's about the performing arts, because they knew I understood the demands that they were going through.
And Dawn, go ahead.
Well, after I was hired by Cirque, it just kind of obviously it's like a sports team, you're assigned to a show. When you're in Vegas or when you're at the resident shows, there's a bunch of shows, so you kind of bounce around a little bit. You can help in and fill in. So it was kind of nice that I would actually get to know people at other shows. They'd come over on their dark times. You know, the shows go dark for 2 weeks at a time. We do their rehabs, just like if we were a sports team and somebody was filling in, well, basketball was on the road. So that's kind of how I got into it. Obviously, I do just heard from one of my uh, teeterboard guys from 2003. He's now a stunt guy in New York. He had his neck operated on. He was asking me all these questions, and I'm like, literally, I haven't talked to you in almost 20 years. Like, this is crazy. So, I think it is like what Heather talked about, like the community. Like, obviously, he needs to start some rehab. Obviously, he's in New York City. I need to send him somewhere good. So, I just feel like there is definitely like a camaraderie, if you will, of groups with the circus. So I think that's probably why I stuck around for so long, a long time with one group.
And then back to Emily.
Yeah, it's kind of like what Dawn and Heather are saying. There is such in the circus as a performer, you have to develop a level of trust with the people you work with. And that's from the performance side of things. And you develop that with your provider as well. And when you have a provider who understands the demands of the body that you put so much value on as your tool and the thing that helps you make money, there's a lot to be said for that. These performers are definitely looking for clinicians who understand the basics of their vocabulary or aren't going to just tell them to stop doing the thing, which isn't answering your question, but I was just off of what Dawn and Heather said. Since I was a performer first, I kind of came into it from that side. I started clinical practice after graduating and knew I'd always have some of my peers coming in. So I was still teaching circus even after graduating PT school. So I worked in a circus school and I worked in a clinic, and my coworkers from the circus school would come in as patients. My students would come in as patients, hopefully not as many of those. We were teaching them safely. But yeah, so I started having folks coming in from the circus school. I eventually did stop teaching at the circus school, but everyone knew that I spoke circus, right? Like I understood their mentality and the way that they worked, and it just kind of kept growing from there. So the word of mouth kept growing, and then the circus community was like, oh, there's one of our own that's now in this medical world, because I have been doing this a while. And so they started asking me to, provide education for instructors and things like that. And so it just kind of sucks you in more and more. Like once they know, the circus artists know, they got you. They're so excited to have people that want to help and support them, just like any other performing arts community.
And Emily, you had mentioned how there's a newer sense of performers taking advocacy for themselves. Can you speak a little bit to whether it's common for, say, at the school level for these artists to have access to care, or is it still pretty atypical and they're finding it in the external community?
It is pretty atypical. So like the big schools, the professional schools, where folks are going on to that next level where they're actually, first of all, not all circus performers will go through a professional school, but the professional schools, the degree granting schools, they all have care on site. The schools in your community generally do not and would love to have a resource in their community. And if you have any interest in this population, I beg you, I ask you, please go make friends with the owners of the studios. They may be too busy to talk to you the first time, but it's not you. It's the fact that they're trying to run a business and they're usually doing it solo. They're very small and they're just trying to keep everybody up and happy and moving. So there's a lot of opportunity to be a community resource for the population.
I see Dawn has her hand up. So yes, Dawn.
This kind of goes back to what Emily and Heather both said about the dancers kind of going into circus. I see a lot of dancers where I work currently, and I would say almost every single one, as they're finishing their rehab, let's say they're doing knee rehab, whatever, ankle, they're like, oh, can you kind of help me get ready to go train tissue? Like they all want to go do silks. They all want to learn something. Like I have one that wants to do hoop right now. I'm like, you're not the strongest girl. So we had to like come up with all these kind of baseline levels, but I think that's also a venue into a lot of dancers now have to have some aerial skills, and that's really, really common. And I don't know that most of them have any kind of baseline training, or even the training that they might get might not be great, or they expect them to come in with a certain level of like strength and ability. So I've seen a lot of that in the 3 years at the college level where I work currently. So just kind of threw that in. It's kind of off topic now, sorry.
Yeah, no, totally. There's a study that was showing the more dance specific, weaker shoulders were more inclined to injuries. Because a lot of them do to make that transition. And there are a lot of cruise ships who are adding on all these aerial acts and having people who don't have the training come in, learn how to do this on a moving ship. I've had a lot of patients come after the cruise and tell me about all the stuff they had to learn.
I think all the cruise ships that cast down in Florida all require one aerial skill. They have to do an aerial skill in their audition now. So
nice.
Yeah.
Not a few years ago.
That's a very interesting point. As a side note, I work with the Colorado Ballet, and they just did Alice in Wonderland as their performance, which included a harness for growing Alice. And I was even taken aback, like, how do we know this person's ready to do this when it's not a skill that's in their common practice? So I think the aerial arts specifically are, a whole different ballgame. Like you said, Dawn, it's not like you just transition to that because you think you want to do it. That requires an entirely different approach.
And in the independent study course, there's a case study that includes a harness for low back.
Wonderful.
Man.
So with all of our background information on the common injuries we see, how our presenters have gotten into the populations that they are, I've asked them each to kind of share some clinical pearls or strategies in treating these unique artists. And I think who we said Dawn was going to address specifically the loading and returning to full capacity.
So I think in general, this has to be multifactorial, meaning it can't just be coming from the rehab side. Like you also have to incorporate, even at the rec level, whatever level you're at, it has to include a certain amount of training. It has to include like, I mean, we even incorporate like nutrition and massage days, and so all of those things need to be included. You can't just have a rehab plan that goes from 0 to 100 without these like kind of steps that also include off days. And you have to come up with some way to quantify it. Like even in my most general integration plans, even at the circus, I remember talking to like, it was this guy who does this slippery surface. I don't know how I'm going to integrate you. Like you're having hip pain, like we just had to tell him, and he doesn't have a coach. He's his own coach. Like it was just like rehab and him. And so basically you can't modify it so that he's partly in the show. He's either doing his full act or he's not. He's a solo performer. So there was lots of discussion like, okay, you're just going to do 50% of your performance today. Like that was just how we basically broke it down as an integration. Next week, you're going to do 75%. The following week, you're going to do 80 to 100, and you're going to do it twice a day. Like we just had to break it up. So I think there has to be, everybody has to agree on it. You can't have just like rehab giving the plan. That's never going to work. And there has to be this kind of roadmap where the performer can see the end. You can't just be like, and in 2 weeks, we're going to readdress. Like, okay, that might be the overall plan for right now, but in 2 weeks, you also need to have like this other idea that they're eventually going to be back to full. Because when I was at Cirque du Soleil, there were a lot of people that I had to answer to, coaches, assistant coaches, artist coaches, perform like act coaches, not to mention artistic directors and stage managers, because it all kind of falls into having a gap is going to affect the rest of the performers. Somebody's going to have to do these jobs. So there was always like a big puzzle, and it was always very, but they had to be ready by this time. And if they're not, here's what's going to happen. So I think multifactorial, there's a big push right now that the athlete really needs to be engaged in part of the process as well. And I think we used to, like when I first came out of school, we just give them plans and say, this is it. We never ask them. And so now I think it's almost disrespectful if I'm not including them in the process. So I would never do that, even with my athletes right now. So that's my big thing.
And I know this discussion often comes up, what do you use to guide that return to full participation? Are you leaning on the literature from climbing, from other overhead athletes? Like, what are you using objectively to guide those decisions?
So at the Circus, even, in 2003 when I started, we had baseline measurements of them. I would say we didn't know what baseline measurements we needed to take necessarily, but we had some. So I think that's probably the best. In the athletic population, there tends to be a lot of baseline as well now. Like we have, force decks, we have all this kind of magic number or objectifying, quantifying data. I think in the Circus, there's also a lot of, well, I can do it, I can push through it so my team doesn't struggle as well, or so somebody else doesn't get hurt because they have a sore shoulder and I don't want them to get worse. So I think there's a lot of like, collaboration, and like they want to help each other out as well. So you can't just come in and be like, no, it has to be this way. There has to be like a little bit of give and pull. I don't know that there's a ton of specific research. We ran into this when we were writing the ISC. We kind of just extrapolated as best we could from athletics and other, like, I know Emily had worked with Behe on some, Jared's his name, right, on some climbing a couple of years ago. So I think there is some data out there. We just don't know if all of it's relevant yet.
Heather, what do you have to contribute to our clinical pearls in returning to full capacity?
Well, so most of my area, I mostly have aerialists in clinic or pole dancer, and it's teachers, recreational, and then the teachers usually also do like nightclub gigs. So they're usually solo acts. And they have a lot of independence at least. But as Dawn said, like we work in conjunction. Very rarely can they just stop doing things because they have to make their money. They have to teach to eat. So very much I'll explore like, the 1, 2, 3 pain during that goes away when they're done and doesn't cause more pain later. We can work with that. If it causes the 4 out of 10 pain, sharp pain, or they have pain later after doing stuff, then it was just too much. And so they'll adjust their teaching and their acts as they rehab and try to strengthen back into their full range and strength. In terms of like musculoskeletal, in terms of pelvic floor, if you're having leaking with an activity, you've overloaded your pelvic floor function. And so then again, that's like your indicator of where you need to adjust and slide the scale so that you're not leaking with your movement, and then building from there.
And then Emily.
It was really great I'm glad I get to go third. It was just really great because I'm listening to Dawn talk and I'm like, oh yeah, you're pointing out like the clinical pearls that Dawn included without even meaning to, or also meaning to, but like the big things are like taking the artist's goals, in her case, the director's goals, like the show goals, into consideration, even from the beginning. How do we get from A to B or A to Z? Um, and it's always about that end point, and that can be true even for a recreational artist. The end point may be, I want to hang from my arms again. We relevant to that and to them, they're going to be able to participate more fully in their care, and they're going to be excited about getting to that end goal. Creativity was another thing that I think was talked about kind of on from both Dawn and Heather, is that the creativity of, hey, we don't have solid numbers, but we do have a lot of information about how this patient interacts with the world, and how we can use uh, pain and response to load as kind of our guide, and creativity in the, I don't know how to adapt this. Okay, do 50% of it. I don't know. We're really working with our patients to get creative of, all right, I need to make an exercise that allows you to train for something that's upside down, sideways, and backwards on one pinky toe, right? Like, okay, let's figure this out together. Let's break it down. What does this feel like? Does that feel close? And so really that collaboration, which is another one of those clinical pearls, that collaboration with the artist, with that patient in front of you, and then on the recreational level, possibly with their coach or studio owner, to allow them to participate in class, maybe halfway. Maybe that's talking to them about, if it's a youth who's like in like maybe their ongoing programming, maybe it's figuring out how they can participate or watch, and possibly figuring out payment plans or things like that. Because often you're like, oh, this comes across again in the dance world as well. You can't dance, you can't participate right now. And the school's like, yeah, but we need your tuition, otherwise you really can't show up. Like, how does this work, and how do we collaborate on that together to make it work for everybody so they're able to get that return to sport loading as well? It is an interesting return to sport. We do have a little bit of data. Some of that's been established by our other ISC author, Stephanie Greenspan, did a study through a bunch of the different circus schools. Unfortunately, it did lead into the pandemic, but we do have data from a bunch of the schools. Dawn, were you actually on that study as well, or no? Okay. I was one of the PTs here in Seattle on that study, and there were 9 other sites around the country. Each of them had a PT, and so we got some baseline data for artists and then looked at their injury rates, so you can find her research out there. There was also some data on some normative values from a Huberman study from a couple years earlier, I think 2020. There's not a ton. That, like, the fact that I'm like, here, there's 2, right? Like, I know the names of them, there's only a few. I'm in the process right now with another collaborator on getting some return to sport testing of the shoulder, getting some normative data for that. We just submitted our IRB last week, so we did a pilot study in the fall. And hopefully we'll be doing more going into the next year for that. So there's more and more coming out in the circus world that will aid and assist us with that return to sport and return to play. But it comes down to that creativity and collaboration that allows us to get there, and to use the data that we do have to move us forward. So we are pulling stuff from the gymnastics and tumbling world when we're talking about ground acrobats. When we're talking about aerial, we also sometimes pull from the gymnastics world, sometimes even from the climbing world with grip stuff. But honestly, as the data is coming out, it's really showing that they are kind of different. So part of the problem with circus, and one of the things that makes it so cool, is it can encompass everything. So if you think about the problems of a juggler versus an aerialist versus a hand balancer versus a porter that's throwing and lifting up another person, versus sometimes a singer or a dancer might also be incorporated into a circus show. The demands on all of those different bodies to create this thing that we call circus, depending on what their discipline is, it's going to really change what literature you're going to look to and pull from. So I can't give you one place to look at. I can tell you to use your creative brains, creative eyes, and skill set to really pull in things from whatever seems relevant, and to talk to your patient. And I find this population, again, because their bodies are so important to them, they're really open to the collaboration, and it's okay to say, do you have a video of that? And to say, I don't know, can you show me? all they want to do is show you the cool stuff they learned the other day in class, right? Like it's totally fine. So don't be afraid to say, show it to me.
Thank you. What I enjoy hearing across all of our disciplines, especially in the performing arts, is that we all treat these unique individuals, but at the end of the day, we're using the same formula, right? We're drawn to this because we have to be creative, we have to be collaborative, we have to take the individual needs of the performer in front of us and figure out how we can optimize what they're trying to do. So I like to say it simplifies it a lot to say, like, okay, I have a circus artist in front of me. I have no idea what they do, but I follow the same guidance that I would for a dancer, for a football player. If I don't know, I ask, show me the movement and help me create the way that we get you back to doing that. So I like hearing the insight from all of you on that. Along those lines, for people that are, say, kind of testing the waters with getting involved with treating circus artists, do you have specific resources or any other professional groups that you would guide people to? You can speak freely. I don't need to assign you to answer that.
I do think that circus, again, because it is so multidisciplinary, has been picked up a little bit by other organizations as well. So if you're looking for other conferences and organizations to be a part of, IADAMS, the International Association of Dance, Medicine, and Science, also allows some circus presentations in there. Depending on where they are in the world, some more or less of them will get into their conference. So this year their conference is in Vegas, so there will probably be a nice little circus cohort of stuff going on there. And then the other one is PAMA, the Performing Arts Medical Association. I am co-chairing the conference this year. The schedule is now up. It's in July in DC. Come join me and play. And then the best resources for this is another resource is the American Youth Circus Organization and American Circus Educators. Our name is too long, but it is a national organization focusing on circus education in the United States. And so you can get resources about connecting with different circus schools. We have some resources on that website as well for a little bit more about circus stuff. On the PASIG website, there is a vocabulary list somewhere, buried somewhere, and some injury lists that I think Dawn and I collaborated on ages ago. I just remembered that. I was like, yeah, that was forever ago. And then, of course, the ISC. If you are a clinician who works with circus artists, on my website is a free resource to artists. You can put your information in there, and then artists can find you more easily as well. I think those are all the big ones. But yeah, the ISC is a labor that the three of us and Stephanie put a lot of work into, so that is in existence for you as a resource. It has a lot of the things that we talked about today in it.
Those are all great resources. Can you put the two organizations that were circus related in the chat that you mentioned so people can find them again? Dawn or Heather, anything else to add? No.
I just wanted to say something about the ISC. Another great thing about it is particularly for folks who are not as familiar with circus arts is that you have pictures and videos that the reader has access to that someone may not recognize comes along with this little booklet. So just for anyone who has not purchased it yet, highly recommend it as a resource. And when you get a chance, Melissa, I'm ready to ask a question.
I was going to say, with that being said, we have some time left, so I can open the floor for a few questions if anybody has. Laurel.
My biggest question is for folks who don't regularly work with circus artists and may have not had that in their background, what are the biggest mistakes that people make? Or is there any kind of management of a common injury that you might treat, the 56-year-old soccer mom one way, but you really would approach it differently if it was a circus artist? I don't know if that's the case. Is my pickleball shoulder injury going to be managed differently than your circus artist shoulder injury? So like, what are those kinds of examples? Where might I go wrong? if I'm really a novice with circus artists, and have only treated, tennis players and other people. That's for anyone.
I actually hear Emily in my head with this one, but she already said it. You can't really tell them no. Like you have to come up with a plan. You can't just be like, no, you can't do this. And if you do have to go that route, well, what can you do? I mean, I feel like that's also really important, like at the professional level, it's a job at the end of the day. So it's a work related injury, and we have to get them in the environment as soon as possible. That's actually statistically out there if you ever listen to any OC health stuff. So if you have a big injury, even if it's like an ACL, we need to get you in the environment as soon as possible. So you have to come to practice, you have to help out, you have to help. If you can launch, then you're launching. That's the harness where they're on a so they don't fall. Like you have to be really involved and try and keep involved. Even if you're not going to perform for 9, 10, whatever months, like we still have to get you in the environment as soon as possible. And I don't know if like the soccer mom or the pickleball mom, I don't know that we necessarily want you around the pickleballers as soon as possible. Like, yeah, we want to integrate you and like ramp up your load, but I don't know if we want you hanging around the courts necessarily, if that makes sense. And I feel like that was a big thing. That the circus really, especially the shows that I was at, we really wanted them to be around as much as possible and to feel like they're still part of the show versus like sitting at home, getting depressed, doing God knows what in Vegas. So yeah.
Thank you for that, Dawn.
The
And then
other
I will,
thing, oh, Heather, go ahead. Do you want to? Okay. One of the things, so yeah, telling them no, it's like telling anybody, like, stop running. Like, just because you don't know what it is that they're doing, trying to modify is gonna be more important, or just as important with this population as it is for other athletes that really identify as the thing. Again, something that we touch upon, the culture in the ISC is just like, this is a culture of identifying as a circus artist, even at the recreational level. So recognizing that it's not just stop doing that, right? Like we all know not to say that to our people, but I think it happens more and more in the circus community, especially. There is a large percentage of these recreational artists that are over 50. And they're, you get the normal stuff of ageism and athletes, and then you add turning upside down or pole dancing for some of them, and you get a lot of don't do that, why don't you go golf type things. So that's just yes and to what Dawn said. The other thing is the difference comes back to also that like overhead athlete thing. So if you're talking about someone who's playing pickleball, they may spend most of their time down here. They may serve, right, or tennis. But we really need to make sure we're not just working that rotator cuff as a stabilizer down by their sides or even out here. It needs to be working way up overhead. Their hips need to be working and strong in all that end range. So kind of going way back to the very beginning of this conversation, there's that importance of end range strength is where people tend to miss in this population, is that there's like it's not just working in mid range.
And Heather, did you have something to add?
I was just going to say the thing about in-range strength and Millie did.
Great job, Emily.
Look how collaborative we are. We're all working together. It's circusy.
Other questions from our attendees?
I have a question, and I will give the caveat that I've been primed for this because I just got out of a con ed on EDS. So how much of your time is spent with looking at other systems? And I feel like this might trend more towards the professional circus artist, but that could be a wrong assumption by me.
Uh, so okay, let's just say yes a lot because I feel like especially the contortionists, so usually the contortionists have a very severe right on the spectrum. They have EDS and then like even more, right? Um, some of the contortionists have been trained, like if they're from Mongolia, they've learned this from a very young age. Some like the Ukrainian male who's on one of the shows right now, he's just born like that. But they also have so many other things that we can like predict. They're going to have low blood pressure issues. They're going to have GI stuff. On tour, that's a real problem because when we're in a country that we have food that they're not used to and they're kind of not eating and not loading, getting the nutrients that they actually need, they're kind of inadvertently going into like that red S, where they don't like the food. It is problematic. So I feel like when I was on a resident show, we had nutrition and like dietitians set up that we could like send them and kind of get that managed, and they could help us with a lot of the GI issues like performing late at night, finishing your load at 1 a.m., getting home. Do you really eat a big dinner then, or do you eat your big dinner between shows when you have 90 minutes and that's it? Or one of the shows only has like 60 minutes in a turnaround. So managing those things are really unique. But those were also unique in just that performance, not necessarily with the kids, the girls that all have EDS or all this hypermobility stuff. So in the resident shows, we had like our kind of go-to doctors that could help us manage this. I feel like on tour, it wasn't as easy, especially given whatever country we were in. We would kind of avoid sending them to the medical professional, I would say, like that. We're not going to send them to a GI doctor necessarily until it gets like really bad, just because I think we would get a lot of really difficult management strategies that maybe aren't really even appropriate for that population. So that kind of sounds negative, like we weren't necessarily withholding care, but it's just not going to be helpful. And I think, especially with the Eastern Europeans and the Chinese, this is kind of like a norm. They don't really see it. Like Western medicine almost visualizes hypermobility as kind of all these problems, and I feel like the Eastern Europeans almost don't see it that way. The Chinese don't see it as a negative thing. This is just kind of how it is. So I think there is some different kind of cultural differences as well. So long answer, but depends. And yes, we used to get them, especially a lot of nutritional help there.
Quick follow-up. Were they good about reporting those symptoms to you, or did you like have to specifically ask, like how much education did they have around that?
Especially on tour, I never had any problems getting information. Like I feel like it was, we eat together, we live together, we take the bus to and from site together, depending on what city we're in. We were even on public transportation. I feel like I was with these people 24/7, so I never really had any problems finding anything out. Uh, Food's catered sometimes it's not. It was all, sometimes they travel with the chef if they're in the tent. So all that information was really easy to get, I would say. Yeah. And I think, like, I can think of one case in particular. She's still a performer, but she ended up having like Wolf Parker, the WPW syndrome, where her hands were going purple. It's a heart condition. And for years, her doctor in the Ukraine had just told her, oh, it's because she's hypermobile. And so finally we got it managed in Montreal, but it was kind of a whole system of like, these aren't right symptoms. And she would just kind of keep blowing them off. She actually didn't want medical care until we were in Montreal. She finally agreed. But so I feel like definitely didn't have trouble getting the symptoms reported.
I think it's really interesting from like on the more recreational side. It is like, Rosie, you were saying like, oh, it's probably more of a professional thing. I do so much education around hypermobility. And while they're fine telling you their symptoms, I have a lot of things on my intake to ask about it, because I'll ask about GI, I'll ask about neurodivergence, I'll ask about POTS, all these things that they don't know are related to the fact that they're coming in because their hip keeps dislocating, right? Like they don't know yet. So I do a lot of education around hypermobility. And I'm actually guessing Heather's similar as well. So I think as we're learning more about hypermobility in general and EDS in particular, and as I think, kind of to what Dawn was saying, globally realizing that maybe it's not so hypermobility as it's the norm for a large number of people in our population, that there is a lot more of it as we learn more about it, and how the body kind of works and comes together. So there's a huge amount, I think, just like in the dance world, there are folks that are drawn to circus because they can do cool things with their bodies. And we may see it in a teen or adult population that may not have had that exposure earlier. So I do a lot of conversations around that.
Yeah, as Emily said, it's a lot of education about where their true end range is versus what they think their end range is with the hypermobility, and learning where the stopping point is for their alignment, because they don't know, because their body can go more.
The other actually really cool thing about circus and hypermobility is because the emphasis for a lot of circus is that end range strength. I actually think it can be really helpful in hypermobility when it's taught well. So it's actually teaching them to control that massive, massive range of motion. And ideally, again, taught well, even contortion, it's about being strong there. It's not about flopping into it. So a really good contortion coach or a really good circus coach is going to teach them to move safely in, out, and through the position. So it can be a really actually quite
Great discussion on that question. Thank you, Rosie. We probably have time for one last question.
I had a question. I was curious how you kind of deal with like the psychosocial aspect of circus artists. So I know it's more on like the extreme side of the spectrum in terms of art and sports. And so like are there specific like mental blocks you've noticed with this population, and like how do you help your patients through those?
yes. I think they come in a couple different forms depending on the artist and depending on their level, but not always. There's the ones who are terrified about the thing that happened and it possibly happening again. And that component, there's the ones that are kind of almost in denial that of whatever's going on. Then there's the ones who are actively not seeking care because they don't want to acknowledge that they've had an injury. Because it is so community based, there is a lot of self-imposed judgment about what it is to be injured and what it is to do circus. There is some cool, there's a free, oh yeah, I didn't even mention it. There's a free access journal called Circus Arts Life and Science. So there was a fun article. I think it was in there. Oh goodness, I think it was in there. I'll put the link in the chat in a second. From like an artist's perspective of like what it means to be an artist and the identification with hurt and pain that it means to be a circus artist. And so sometimes convincing someone that they don't have to be in that much pain or it doesn't need to hurt that way is another conversation that's kind of going on. So there's, the individual and building up the fear and the building up to the thing that is scary, that confidence in both their movement and then their actual skill and their discipline. So it's like, okay, you are physically strong enough. Now we need to practice it 1 foot off the ground, 2 feet off the ground, 5 feet off the ground, with lights, with music, with, and every step of that. So it's something like you would do often with concussion, but you're doing it for their mental health and well-being and their confidence to be able to perform it again on stage. And I will find that link.
All right, great questions. Thanks for all the added insight. And thank you to our wonderful panelists for sharing their circus arts experience and expertise. That will conclude this panel. As Laurel said at the beginning, we're striving to have about 4 panels a year from PASIG. Our next one later this summer will be on pain, and then a more student-focused one toward the end of the year. Emily just posted that last article she mentioned. Great.
Actually, the entire journal, so you have access to lots of stuff
wonderful
that's in there, and it's all open access.
And then if anyone has further questions for the panelists, you can reach out to them. This recording will be available from AOPT. Tara Fredrickson will push it out at a later date. So if you have colleagues that missed it, please let them know. And then don't forget, of course, to check out the Circus Arts ISC if you haven't done that already.
And before everyone goes, I just want to, in front of all of you, thank Melissa for coordinating this panel and working with our panelists to make this all happen. You're doing a phenomenal job as our VP Ed, and we appreciate you. Thank you again to all of our panelists. And if you haven't seen it, check out the ISC. Not just plugging it because PASIG helped put it out. I'm plugging it because it really is a great resource for orthopedic clinicians. So check it out and hope to see you at our next event.